All right, guys, so here we go. This is Chapter 7 of the Emergency Medical Responder course, Airway Management. This chapter, we're going to be talking some more about the structures of the airway, how we move air in and out of our bodies, as well as respirations, how that oxygen is used in our body. We're going to talk some stuff about, there's going to be some stuff in here concerning CPR, which we'll cover even more when we do our CPR training, but it is good to learn it now. Quickly go over our competencies, airway management, respiration, and artificial ventilation. Airway management within the scope and practice of the emergency medical responder. I'm going to talk about, like I said, the airway anatomy, airway assessment, techniques of ensuring a patent airway. Patent means open, essentially. Respirations, the anatomy of the respiratory system. So, once again, we're talking about the airway anatomy and the anatomy of the respiratory system. Respiration continued, physiology and pathophys of respiration, pulmonary ventilation, oxygenation, respiration, what these all mean, external, internal, and cellular. Assessment and management of adequate and inadequate respiration. We'll talk about supplemental oxygen therapy, artificial ventilation, and assessment and management of adequate and inadequate ventilation. We'll talk about artificial ventilation. And with that, we'll talk about minute ventilation, alveolar ventilation, and the effect of artificial ventilation on cardiac output. Pathophysiology uses simple knowledge of shock and respiratory compromise to respond to life threats. Medicine recognizes and manages life threats based on assessment findings of patient with a medical emergency while awaiting additional emergency response. More competencies, respiratory, anatomy, signs, symptoms, management of the upper airway, lower airway. So, two most important life-saving skills. One is going to be airway care and rescue breathing. When we talk about life-saving skills, we talk about the ABCs, which is airway, breathing, and circulation. So something that everybody needs to survive. We have to have an airway. We have to have an open airway without any obstructions. We have to breathe. We have to keep that oxygen coming in and the waste products, CO2, going out. And then we also have to have the circulation to move that oxygenated blood. Once it's in the body, we need to move it around, and that's where the circulation comes from. To maintain life, all humans must have food, water, and oxygen. We can get by a couple days without food, a day or so without water, but oxygen we need all the time. A lack of oxygen, even for a few minutes, can result in irreversible damage and death. Some of the most sensitive cells in our body are located in the brain, and if these cells are deprived of oxygen for 4 to 6 minutes or more, they can begin to die. Brain cells cannot be replaced. They don't come back once we've killed them off. So we need to make sure that we're constantly getting good oxygen to those cells. So just like we talked about when we talked about the human body, the main purpose of the respiratory system is to provide oxygen and remove that carbon dioxide, those waste products, from the red blood cells. Here's this is our respiratory system. We start in our upper airway. We have the nasal cavity, and then the mouth there. The nasopharynx and the oropharynx, so these are the passageways. Naso, meaning nose, is the passageway that goes from the nose down into the lower airway. The oropharynx, so oro, just like oral, this is the passageway from the mouth down to those lower airways. They join up in the pharynx, so we took the nasopharynx and the oropharynx. They combine in the pharynx. Head down. In that passageway, we have the epiglottis, which is a small flap of skin to keep food or other foreign objects out of the trachea. And the larynx, which would be our in males, it's the Adam's apple. It's our voice box. So something to remember in this upper airway, we have inside the mouth the tongue. When a person loses consciousness, that muscle, that tongue, tends to relax and is able to fall backward into the rear mouth, and that can block the passage of air from both the nose and the mouth to the lungs. When this happens, we're going to usually hear a snoring sound, snoring respirations. That's one of the biggest causes of a obstructed airway is the tongue. Then moving on here into the lower airway. So we have our trachea. It's bringing down our air, our oxygen. We've just inhaled it. It's passed through the upper. Moved into the lower. Got to go down the trachea first. It's going to hit the carina, which is that Y shape there at the bottom of the trachea. It's going to divide into two. It's going to go into the right and left lung. From there, we go down into the main bronchus, then down to the bronchioles, and once again, we're going to go over it one more time. We hit these alveoli. These are all little sacs inside the lungs, and here you can see. I think this is a better picture than what we saw last time in the human body. We have our depleted oxygen, our blood without oxygen. It's this blue side. It's carrying all our CO2. Comes down into the alveoli, and across that capillary network, it exchanges the waste products, the CO2, for oxygen. And then so now our blood is oxygenated, and it's going to pass back through, and we're going to head back to the heart this way. Once again, like I said earlier, unconscious patient lying on his or her back, the passage of air through both the nose and mouth may be blocked by the tongue. The tongue is attached to the lower jaw, and if it blocks the airway, it can often produce a snoring sound. So just like I said earlier. And then this will be a diagram of that. So in this left side, you can see where the tongue is falling back. It's obstructing our airway. Here, in this conscious person, I guess, the airway's open because he's conscious. It's not that tongue's sitting there in the mouth properly. Some other parts of the respiratory system, we've already talked about this. We'll just go over it. At the back of the throat are two passages, the esophagus and the trachea. The esophagus is where food goes through. Trachea is for air. That little flap of skin we talked about. Epiglottis, it'll separate, it keeps the esophagus and trachea separate, keeps food and water from entering that airway. Once again, down into the lower airways, divide into the bronchi, and then we have lungs on either side of the heart. So the smaller airways that branch from the bronchi are called bronchioles. Bronchioles end in tiny air sacs called alveoli. Gone over this quite a few times. The exchange of oxygen and carbon dioxide that occurs in the alveoli is called alveolar ventilation. That's what it's called when we're moving the oxygen and the carbon dioxide across that capillary bed there in the alveoli. And this is an even better picture than the one we talked about earlier. Just want you guys to completely 100% understand this. We got our deoxygenated blood carried from the heart to the lungs by the pulmonary arteries and that word. Right there in the alveoli, the gas exchange takes place at the capillary level. Those capillaries are covering all those alveoli. And then oxygenated blood is carried from the lungs back to the heart by the pulmonary veins and venules. So the lungs consist of a soft, spongy tissue with no muscle. Movement of air into the lungs depends on movement of the rib cage and the diaphragm. When that diaphragm contracts during inhalation, it flattens and moves downward. So generally, when it's relaxed, it's a dome shape, and it sits higher up in your torso. When you inhale, it contracts and flattens. It moves downward, giving you more space to bring in air, as well as your rib cage opens up to increase the size of the cavity and help draw that air in. Then once again, on exhalation, that diaphragm is going to relax and become dome shaped. So here we're going to see that in a picture. The diaphragm contracts, flattens out, goes down, and the chest cavity gets bigger to allow those lungs to inflate. Then when we breathe out, everything's going to relax, diaphragms become dome shaped again, and that chest cavity is going to come back in. Some things to consider with respiratory systems, in regards to respiratory systems. Children and infants, they're smaller than they are in adults, so those air passages become more easily blocked by secretions, foreign objects, as well as the tongue. The tongue is proportionally larger than it is in adults, so if it's one of the major causes of airway obstruction in adults, it's even more so for children. We also have the trachea in children and infants is more flexible, so when we do maneuvers with their heads, it's possible to kink off or close that airway. Their heads are generally bigger than that of an adult compared to their body size. So we need to learn some different techniques for opening the airways on children and infants. Children and infants also have smaller lungs, which means they take smaller breaths. So when we're doing rescue breaths, we need to be giving them smaller breaths. We need to keep that in mind. Most children and infants, when they experience cardiac arrest, it's usually not based on heart conditions. Remember, I said usually, sometimes it is. Usually it is a breathing issue, a respirations issue. Something's going on with their breathing, and that's what generally causes death or cardiac arrest in infants, not necessarily a heart issue. A is for airway. So throughout your EMS career, whether you are a EMR for the rest of your life until you retire, if you become an EMT, a paramedic, whatever, ABCs. We always talk about ABCs. Doctors doing their CPR training, when they have to get recertified for CPR, they learn ABCs because it's easy and that's how we do it. A is for airway, B is for breathing, C is for circulation. So it's important to remember that in healthy individuals, the airway automatically stays open. It's automatically patent. That patent means open. That's a word you might hear me say throughout this, or in your time in EMS. Patent is open. An injured or seriously ill person is not able to protect that airway, and it might become blocked. It's our job to check that airway and correct the problem. So, one of the first things we're doing when we're checking airway is we start with just checking for responsiveness. We ask the patient, "Hey, are you okay? Can you hear me? Talk to me. What's going on?" If you get a response, you can assume that the patient is conscious and has an open airway. If there is no response, we want to gently shake the patient, repeat the questions, keep talking to him, try and get a response out of him. If you've just come across this patient, if you just found somebody lying on the floor, first thing we need to do is call 911. If you're responding to a 911 call, obviously we don't have to first call 911. We then want to position the patient by supporting the head and neck and putting them on their backs. We want to quickly scan the patient's chest for breathing and check for a pulse. If they have a pulse but are not breathing, we need to correct the airway. So we got a pulse, we got no chest rise and fall. We need to open the airway and see if that's the problem. To open that airway, we are going to use the head tilt chin lift maneuver. So the patient's on their back. We're going to put one hand on the patient's forehead and apply pressure backward. We're going to put the tip of our fingers under the bony part of the lower jaw. So it's important that it goes on the bony part of the jaw, not into that soft tissue right there under the jaw, because you could be putting if you do it into that soft tissue, you can be blocking off their airway. Your airway runs right through there, so we want to make sure that it's on the bony part and not on the soft tissue. Once we have it positioned there correctly, we're going to lift the chin forward and tilt that head back. Now, if we come upon a patient, we suspect a neck injury from they fell, they were in a car crash, they dove into a pond and something happened and we suspect they might have a neck injury, we want to use the jaw thrust maneuver. To do that, once again, patient's on their back. We're going to place our fingers behind the lower jaw and move the jaw forward. We're going to tilt the head back into a neutral or slight sniffing position. And then we're going to use our thumbs to pull down on the lower jaw, opening the mouth enough to allow breathing. Here you can see that. Here we have the patient's on their back. You put your fingers behind the lower jaw and move that jaw forward so the fingers are right there below the ears, right below the jaw. We're going to kind of tilt the head back a little bit. We don't want to be cranking on that neck too much because the reason we're using this is because we suspect a neck injury. And we're going to use our thumbs to pull down on the lower jaw and open that mouth enough to allow breathing. So you can see his mouth is now open here. He's pulled down, open everything up. All right, so we got the airway open. Now we need to check for fluids, foreign bodies, or dentures. Stuff that can block the airway include vomit, mucus, blood, foreign objects, candy, food, dirt, toys in kids, whatever. Dentures or false teeth. If they're loose, we want to go ahead and take them out, secure them somewhere so that after you've saved this person's life, they don't come looking for you trying to find their teeth. So if they're loose, if they're secured in there, they're not going anywhere, we can go ahead and leave them in. If we find anything else in the mouth, we want to remove it. If the mouth is clear, we want to consider using an airway device, an airway adjunct. which we'll talk about here in a couple minutes. So correct the airway using finger sweeps or suction. Finger sweeps, generally you don't want to be putting your fingers in somebody's mouth, but sometimes you're going to have to. I wouldn't go past their teeth with my finger. To snap a finger, it's about the same amount of force as to take a bite out of a carrot. So I wouldn't put my fingers past somebody's teeth. But if you had to get it out from around their cheeks and such, as you can see in the picture on page 113, they're just sweeping around inside the cheeks. You know, sometimes you're going to have to do it. If you don't have a suction device, you got to get that crud out of there. Make sure you have gloves on. Once again, you know, we want to make sure we have gloves on for everything. Suctioning. A suction machine can be helpful for moving that stuff even more so than finger sweeps. So if it's available, manual suction devices. This one's kind of like that one you use for babies when you're sucking boogers out of their nose. You squeeze the bulb here. This ends in their mouth. It's supposed to pull up the fluid, secretions, vomitus, whatever, and then deposit it into this bag. These ones are pretty inexpensive. Should be able to fit into your EMR life support kit. Once again, the end of the suction tip goes into the patient's mouth. You squeeze or pump the hand-powered pump. Start sucking it out. Some services will have mechanical suction devices. This says to clear the patient's mouth with your gloved finger. You should be able to suck up pretty much everything. We want to go ahead and turn it on and then use a rigid catheter to remove the material. We don't want to suction for more than 15 seconds at a time on adults. What ends up happening is that if they're breathing on their own, and you're sitting there suctioning away, they can't get any air down. You're sucking all the air back up into the catheter. With children, a small child, we don't want to do it for longer than 10 seconds, and with infants, no longer than 5. If you need to get any further down into the airway, you can use a flexible tip catheter to get some of that stuff out. Pictures of those two catheters, the rigid suction tip and the flexible suction catheter, are on page 114. This is a portable suction device that all ambulances have on them. Little vacuum motor in this section. All this tubing is connected to the rigid catheter. When you turn on the suction, anything that you suck up gets dumped into this little canister here. All right, now that we've opened the airway, we've cleared the airway, now we need to maintain that airway. So for unconscious patients, we want to continue holding the head tilt, chin lift, or the jaw thrust position. If the patient's breathing adequately on their own, we've opened that airway and they're breathing on their own now, we want to go ahead and place them into the recovery position. The recovery position is for unconscious breathing patients who have not suffered trauma. It'll help keep the airway open. Gravity will keep the patient's tongue and lower jaw from blocking the airway, and any secretions or vomitus or anything else that happens after you've cleared it all out will drain out of the mouth instead of back into the throat. To place that patient in the recovery position, we're going to go ahead and roll them onto their side as we support the head. We're going to place the patient's face on his or her side so that any secretions drain out the mouth. We're going to go ahead and kick this leg out like this so that they can't roll over onto their stomach. We did all that work to open that airway, clear it out. We let them roll their face into the dirt. Well, now we got an airway full of dirt again. We got to get it cleaned out. So that leg helps just keep them from rolling onto their stomach. So airway adjuncts help keep the airway open. they maintain the patient's airway, and, so there's two types: oral, which means mouth, it goes in the mouth, or nasal. The oral one, there's two purposes. It'll maintain the airway, and you were also able to pass a suction catheter past it in order to help suction if we need to. It's used for unconscious patients who are breathing, if they're in respiratory arrest, and they do not have a gag reflex. So if you go to start putting one of these in and they start coughing, hacking, choking on it, they have a gag reflex, and we need to not use the oral airway. Here's a picture of a few. You can see here, this one has a groove that goes down the side, and if you look at it, it goes out on both sides. That allows that suction catheter to get down there and suck stuff out. And this one has a hole that goes through there in order to help suction stuff out. Oral airways continued. They can be used with mechanical breathing devices such as pocket masks or bag valve masks. We need to select the proper size by measuring from the earlobe to the corner of the mouth, and then to insert one, once again we select the proper size. We open the patient's mouth. After we've manually opened the patient's airway, we hold this upside down. So if you're looking at it, naturally you would think that this side here goes against the tongue, and you're right, but when we insert it, this end here goes towards the top of the mouth, or the top of the roof of the mouth. Slide it in until we meet resistance, and then we're going to rotate it 180 degrees. So this end here has gone along the roof of the mouth until we met resistance. We rotate it, and then this curve is sitting along the tongue. The reason for that is, if we were to just shove it in this way, it's possible for this end to catch on the tongue and push it back, and then we don't have an open airway, a patent airway. So we've gone ahead and inserted it. This end rests against the patient's teeth or lips. Back to the continued. Yeah, that was it. Then we move on to nasal airways. These can be used in both unconscious and conscious patients who are not able to maintain an open airway. They're not as likely to cause vomiting. They don't generally cause the gag reflex to occur. One thing is that you cannot suction through a nasal airway. So like we could suction through those oral ones, you can't do it with this one. So for the nasal airway, to insert it, we're going to select the proper size by measuring from the earlobe to the tip of the patient's nose. We want to go ahead and coat it with a water-soluble lubricant, and then we're going to insert it with the bevel end. We'll go back to the picture. You can see how this is cut. It's cut at kind of an angle. This is the bevel. So after we've coated it with the water-soluble lubricant, we're going to usually you want to select the larger nostril to insert this. We're going to stretch that nostril open using the thumb. We're going to gently insert it until this flange here rests against the nose. We don't want to force that airway. If we feel any resistance, we're going to remove it and try and insert it in the other nostril. Something to remember with these nasal airways, if we suspect the patient has head trauma, we don't want to use a nasal airway. We can cause further damage. If the patient suffered head trauma and something's busted up inside their head, we don't want to be poking their brain with one of these nasal airways, because It's possible. Moving on, B is for breathing. You can use the look, listen, and feel technique to assess the adequacy of breathing. You want to look for the rise and fall of the patient's chest, listen for the sounds of air passing in and out of the patient's nose or mouth, or feel for air moving on the side of your face. Something you guys need to remember, because it gets asked a lot, you're going to see it in patient assessment and other places in the book. Normal adults have a resting breathing rate of 12 to 20 breaths a minute. That means they breathe once every 5 to 6 seconds. Signs of inadequate breathing: noisy respirations, wheezing or gurgling, rapid or gasping respirations, pale or blue skin. Blue skin is also known as cyanosis. You can see it around the lips and in the fingers. The most critical sign is respiratory arrest, which is characterized by a lack of chest movement, lack of breath sounds, and a lack of air against the side of your face. So respiratory arrest would be a stoppage of respirations, stoppage of breathing. Some causes of respiratory arrest include heart attacks, a mechanical blockage or obstruction caused by the tongue, vomitus, particularly in a patient weakened by a condition such as a stroke, foreign objects. So foreign objects, when we talk about foreign objects, we're talking about objects that don't belong in the body. Food, candy, such as that. Illnesses and diseases, drug overdoses, poisonings, severe loss of blood, or electrocution by electrical current or lightning. So we want to check for the presence of breathing. Assessment of any motionless patient begins with checking for responsiveness and signs of breathing. So once again, back to, hey buddy, you all right? Shaking them, they don't respond. We're going to get down there, we're going to look for chest rise. We're also going to be checking a pulse at the same time. If the patient is unresponsive, we want to, like I said, check to see if the patient is breathing, looking for that chest rise and fall. So if they're not breathing, we need to correct that. As you perform rescue breathing, we need to keep the patient's airway open. So you guys, this is going to start talking about mouth to mouth. I'm going to tell you right now, except for my loved ones, I'm not putting my mouth on anybody. So that's up to you. They do have pocket masks or face barrier shields. I'm not getting my mouth that close to anybody, like I said, except my loved ones. So this is kind of a thing that you guys need to decide what you want to do. As we perform rescue breathing, keep the patient's airway open. We're going to pinch the nose, take a deep breath, and blow slowly into the mouth for 1 second. Then we remove our mouths and let the lungs deflate. Then we're going to breathe for the patient a second time. After the first 2 breaths, we're going to breathe once into the mouth every 5 to 6 seconds. So like I said earlier, 1 breath every 5 to 6 seconds or 10 to 20 times a minute. These are the pocket masks. Mouth-to-mouth rescue breathing enables you to perform rescue breathing without mouth-to-mouth contact. Reduces the risk of transmitting infectious diseases. To use a mouth-to-mouth ventilation device, we're going to follow the steps in skill 7-4, which is just open the airway using the head tilt chin lift or jaw thrust technique, seal the mask against the patient's face, and then breathe through the mouthpiece. Pretty simple. Here's that mouth-to-mouth. Once again, unless it's one of my loved ones, I'm not putting my mouth on some random stranger I found down on the side of the road. So it does not require any equipment, and says carry somewhat a higher risk of contracting a disease. This is usually what we use for correcting the breathing in patients. It's a bag valve mask. That mask goes over the face of the patient, makes a tight seal. Squeeze the bag, which pushes the air through a one-way valve, through the mask and into the patient's mouth and nose. As the patient exhales, a second one-way valve releases that air. Here we can see two-person bag valve mask. Specific steps for using that bag valve mask are in Skill Drill 7-6. The use of a bag valve mask is best accomplished as a two-person operation. It's hard to maintain that good seal that you need to use this device as one person. It's possible, but it is difficult. So, quick review of the airway and breathing. Airway, we find somebody down, we want to check for responsiveness, shouting, "Okay, are you okay?" Shaking the patient's shoulder. If they're unresponsive, we need to activate EMS, call 911. We're going to place the patient on his or her back. We're going to quickly scan the patient for signs of breathing, check for a pulse. If a pulse is present, we're going to correct the block airway with a head tilt, chin lift, or jaw thrust maneuver. That's going to open our airway. After that airway is open, we want to check the mouth for any secretions, vomitus, or solid foreign objects. If anything's found, we need to clear that out. We can correct that with finger sweeps or suctioning. And then we want to maintain that airway by holding it open or using an oral or nasal airway. Breathing. So now that we got the airway open, we need to check for the presence of breathing while determining responsiveness. We need to correct the lack of breathing by performing rescue breathing, using mouth to mask or mouth to barrier device if available. It's up to you guys, like I said. Performing rescue breathing on children and infants. Rescue breathing for children. We need to remember children are smaller. And we don't have to use as much force to open the airways and tilt their heads. Remember, we also don't want to tilt their heads back too far, because we can go too far and pinch off their trachea. We want to give one rescue breath every 3 to 5 seconds, or about 12 to 20 rescue breaths per minute. So with infants, remember that they're tiny, must be treated extremely gently. So some common causes of airway obstruction, like I talked about earlier, the most common is going to be the tongue. And if it is blocking the airway, we need to do the head tilt, chin lift maneuver or jaw thrust maneuver. That should open the airway. Food is the most common foreign object that causes an airway obstruction. If a foreign body is lodged in the air passage, you must use other techniques to remove it. So that's where we get into suctioning or using the finger sweep. Here's some examples of airway obstructions. First one's going to be our tongue. This one's an injury to the throat here. Caused something to happen. Here we have swelling. So maybe from allergic reaction to something, it's caused that close up, start closing off that airway. And here we have the foreign object in the throat. Types of airway obstruction. So if we come across a patient that seems like they're choking and looks like they have some type of airway obstruction, we need to ask them, are you choking? If the patient can reply, the airway is not completely blocked. If the patient cannot speak or cough, the airway is completely blocked. So this is where we're talking about types of airway obstructions. Mild airway obstructions. The patient's going to cough and gag. The patient may be able to speak, but with difficulty. In that case, we need to encourage the patient to cough, and if they cannot expel the object, we need to arrange for prompt transport. In a severe airway obstruction, the patient is unable to breathe in and out. Speech is impossible. We may also see poor, if they're not breathing in and out, there's not going to be any air exchange, so it is going to be poor. They'll have increased difficulty with the breathing, maybe a silent cough, and they can lose consciousness, in as soon as 3 to 4 minutes. Treatment for this is going to be abdominal thrusts, also known as the Heimlich maneuver. To do that, if the patient is conscious, we're going to stand behind him or her and perform those abdominal thrusts. To assist to do this, we're going to use skill in skill drill 7-8. We want to get behind there. We want to put our fists between the belly button and the bottom of the xiphoid process, and then we're going to pull back. So we're pulling into their stomach, trying to help them move that obstruction out. If they become unresponsive as we're doing this, we're going to immediately start performing CPR. Children with airway obstructions, it's going to be the same thing. We just have to adjust where we place our hands. Should still be between the belly button and the bottom of the xiphoid process. Once again, if they become unresponsive, we're going to do CPR for 5 cycles. We're going to do CPR for 5 cycles, and then we're going to activate the EMS system. Okay. Airway obstructions in the infant. If the infant has an audible cry, the airway is not completely obstructed. If it is completely obstructed, we're going to use a combination of back slaps and chest thrusts. If the infant becomes unresponsive, we're going to ensure that the EMS system has been activated, begin CPR, and then continue CPR until more advanced personnel arrive. Guys, like I said at the beginning of this chapter, this is going into some stuff that we're going to be going over more when we do our CPR course. But it's not bad information to know. So that's what's been going on with some of this. We'll talk more about CPR, choking and Heimlich maneuver, all that good stuff more during our CPR course. So oxygen administration. So normally the air that we breathe contains about 21% oxygen. The room air here that you and I are breathing is about 21%. Now, blood loss, other traumatic injuries, the amount of oxygen that's available to the cells could be insufficient. So administering supplemental oxygen to patients showing signs and symptoms of shock is something that we do to make sure that the cells of the body are still getting that oxygen. Patients who have experienced heart attack, strokes, patients with chronic heart or lung diseases, they might not be able to get sufficient oxygen from room air. They're not getting what they need from that 21% in the air, and so they're definitely going to have some benefit from receiving supplemental oxygen. Our oxygen cylinders are these green bottles here, almost always painted green. The ones that we have in our system, we have portable ones, which you guys should probably have on your trucks, which are D size. Yeah, D's are the small ones. E's are the bigger ones that stay on the truck. And depending on how high we have these regulators turned up, each cylinder should last for about 20 minutes. So like I said, each one's stored at about 2,000 psi, but we can't use it like that. We can't use 2,000 psi right out of the bottle. So we need to put on a regulator or flow meter. It's a single unit attached to the outside of the oxygen cylinder. It can be adjusted to, once that goes on there, the pressure has been reduced to about, it's regulated down to about 50 psi, and then we can further adjust it to about, to deliver oxygen between about 2 to 15 liters per minute. There's a gasket in here that ensures a tight seal. You got to make sure that gasket's on there every time, or else it'll leak. A couple of the more common pieces of equipment we use to deliver oxygen is a nasal cannula. This is a small tubing that goes around the patient's ears, and then there's a small bit that goes up in their nose. It delivers low to medium concentrations of oxygen. Or we have a face mask, which is placed over the patient's nose and mouth to deliver oxygen. Those masks are usually called non-rebreathers. When using oxygen, we need to remember that oxygen supports combustion. Small sparks or flames can turn into serious fires, so don't allow your patient to have a cigarette while you have them on their oxygen. The pressure in an oxygen cylinder can cause an explosion if it's damaged. They should be kept inside sturdy carrying cases. If you break off that regulator end, that can turn your bottle into a missile, a rocket. If you want to see that, there was a good Mythbusters episode about it. It's called Mythbusters Air Cylinder Rocket, just to show. All right, so administering supplemental oxygen. We're going to place the regulator flow meter over the stem of the oxygen cylinder and line up the pins on the pin indexing system. So on that regulator, you're going to see two posts sticking out. Those two posts go in these two holes right here. And this is that gasket I was talking about earlier. We're going to tighten it down by securing the screw firmly. Then we're going to turn the cylinder valve 2 turns counterclockwise. We're going to check the gauge on that pressure regulator flow meter. Then we can open and adjust the flow meter to deliver the desired per liter or liter per minute flow. For nasal cannulas, it's about 1 to 6 liters per minute. The non-rebreathers can go higher, up to 15 liters per minute. When the oxygen begins to flow, that's when we're going to place the face mask or nasal cannula onto the patient's face. So here's that nasal cannula, delivers low flow oxygen at 1 to 6 liters per minute in concentration of 24 to 44% oxygen. We adjust the liter flow on the regulator to 1 to 6 and then apply the cannula to the patient. This is the non-rebreather mask. It has this reservoir here. It's used to deliver high flows of oxygen from 8 to 15. It can deliver concentrations of oxygen up to as high as 90%. These should be used for patients who require higher flows of oxygen, including those experiencing shortness of breath, severe chest pain, carbon monoxide poisoning, congestive heart failure, or signs of symptoms of shock. When we get out this mask, like I said, you want to hook it up to oxygen first, fill up this reservoir, and then attach it to the patient's face. That reservoir stores the oxygen in there for them to intake, and then they breathe out. The exhalations go out these little gaskets here, and then as they're breathing out, this is filling back up. Supplemental oxygen must be used carefully so that you, your team, and the patient remain safe. We'll have some additional skills. We'll do some additional stuff in lab to make sure that you're ready to administer oxygen in emergency situations. Pulse oximetry is used to assess the amount of oxygen saturated in the red blood cells. Pulse oximeter consists of a sensor probe that goes on the finger and then a monitor side. The monitor displays the percent saturation of the patient's blood. In a healthy patient, the oxygen saturation should be between 95 and 100%. The pulse oximeter cannot tell you what is wrong with the patient, but it can help you diagnose them, give you some idea what's going on, recognize the patient is having a problem, determine what your treatment, and also determine whether your treatment is helping the patient or not. The pulse oximeter has certain limitations. It will not give an accurate reading if the patient is wearing nail polish, has dirty fingers, if their hands are cold, if they've lost a lot of blood. They can also get false readings if they've experienced carbon monoxide poisoning. It won't be reading the oxygen saturation. It'll be reading the amount of carbon dioxide or carbon monoxide that's in the blood. Once again, there's no machine that can replace a careful patient assessment. Patient assessment is what we need to be doing. We need to be getting all that information, being a detective and making sure that we're understanding what's going on. So just because we can get all the stuff off our machines, it doesn't always give us all the information we need. So we need to remember that. Sometimes you might come across patients with stomas. You need to check the patient for the presence of a stoma. If we locate one, we don't want to do the head tilt chin lift. We're going to keep the patient's head straight or neck straight. We're going to examine it, clean away any mucus. If there's a breathing tube, we're going to go ahead and remove it. So if I'm not going to give mouth to mouth to some random person, if I find somebody with a stoma, I'm definitely not going to be putting my mouth directly over that stoma. But if you choose to do so, you're going to want to place your mouth directly over it and use the same procedures in mouth-to-mouth breathing. If the patient's chest does not rise, you want to seal the mouth and nose with one hand and breathe through the stoma. You can also use a bag valve mask or a pocket mask in the same way right over the stoma to give them rescue breaths. But you might have to close the mouth and nose to get the air in there. Gastric distension. This occurs when air is forced into the stomach, so we're giving those rescue breaths, and instead of going into the lungs, it's going into the stomach. This increases the chance that the patient will vomit. We need to breathe slowly into the patient's mouth. Remember, just enough to make the chest rise. Dental appliances. So, like I said earlier, do not remove any dental appliance that is firmly attached. This helps keep the patient's mouth full. It forms a better barrier, forms a better surface area for you to get that seal with the bag valve mask. Loose dental appliances can cause problems, so you need to remove them, put them in a safe place. Like I said, you don't want family members coming after you looking for their family, for Meemaw's teeth. Airway management in a vehicle. So use the jaw thrust maneuver if the patient is lying on the floor or seat, or if there's any possibility the crash could have caused a head or spine injury. When we approach a patient in a vehicle, we want to approach them from the side by leaning in through the window or across the seat to do that. We want to grasp the patient's head with both hands, put one hand over the patient's chin and the other hand on the back of the patient's neck. We want to maintain a slight upward pressure to support the head and cervical spine. You can see that here. This technique has several advantages. You don't have to enter the automobile. You can easily monitor the patient's carotid pulse and breathing patterns by using your fingers. This technique stabilizes the patient's cervical spine and it opens the airway. All right, to close it out, the main purpose of the respiratory system is to provide oxygen and to remove carbon dioxide from the red blood cells as they pass through the lungs. When a patient experiences possible respiratory arrest, check for responsiveness, open the blocked airway using one of our maneuvers. We're going to check for obstructions, clear the mouth using finger sweeps or suction. We're going to maintain it by manually holding that airway open or placing the patient in. We're going to maintain the airway by continuing to manually hold the airway open, placing the patient in the recovery position, or by inserting an oral or nasal airway. If it is obstructed in a conscious adult or child, we're going to kneel or stand behind the patient and perform the Heimlich maneuver. Administering supplemental oxygen to patients showing signs and symptoms of shock increases the amount of oxygen delivered to the cells. Pulse oximetry is used to assess the amount of oxygen saturated in the red blood cells. Review real quick. After opening the airway of a patient who has a pulse but is unconscious, you should finger sweep, attempt to insert an oral airway, check for secretions, foreign bodies, or dentures, and perform CPR. So remember, after opening, we want to check for secretions, foreign bodies, or dentures. Number 2, should you place a patient in the recovery? You should place the patient in a recovery position to prevent the patient from going into respiratory arrest, allow secretions to drain from the mouth, protect the patient's spine from injury, facilitate the administration of supplemental oxygen. So the reason we do the recovery position is in order to allow any further secretions to drain out of the mouth. Pulse oximetry. What do we use pulse oximetry for? Assess the amount of oxygen saturated in the red blood cells. Provide supplemental oxygen to the patient. assess how much oxygen the patient requires, or eliminate carbon dioxide from the bloodstream. So remember, pulse oximetry doesn't provide any supplemental oxygen. It doesn't tell you how much to give the patient, and it doesn't eliminate anything from the bloodstream. It's just going to assess how much oxygen is saturated in those red blood cells. There you go. All right, guys. That was Airway, Chapter 7 of the Emergency Medical Responder. We'll talk to you next time.